Fotoghar Maternity Hospital, it's being a tertiary care referral center with 22,000 to 24,000 deliveries per year, which accounts for almost 70 to 80 deliveries per day. This would be, our hospital would be a great platform to do any maternal and newborn projects, research, and it will be our great honor to conduct any resources in our hospital. And it's had been milestones, it has developed lots of milestones in the context of newborn health in Nepal. Just we have established the first human milk bank in Nepal, in Fotoghar Maternity Hospital, and now we have started our newborn screening program also from our hospital, and it's a great honor for us. Let's, for this newborn screening, let's see what we have first done. We have done a feasibility study. I would like to thank Mrs. Janine Khan. We have got contacted with her with the Perinatal Society of Nepal while she came to Nepal to visit Nepal. And we have just discussed, we don't have any newborn screening program in Nepal. We are not doing newborn screening in Nepal. And she said, okay, let's have a plan. And she has made one project. And we have screened almost 825 babies in our hospital. And that was the basis for the national program, that our newborn screening is needed, and it is important to screen our babies. We have the positive cases also. Okay, I'll just go in details about our study. This is the study named Feasibility of Clinical Newborn Metabolic Screening in Nepal, a high-volume maternity center in Nepal. It is published in the BMC Global and Public Health, Volume 2. Okay. Nepal, like many low and middle income countries, is seeking strategies towards achieving the United Nations Sustainable Development Goal to reduce its current neonatal mortality rate from 21 per 1,000 live births to 12 per 1,000 live births. While childhood mortality has seen a 56% decline in 1973 to around 2013 worldwide, the rate of reduction of neonatal death has been much slower, and has in fact increased from 40% to 47% in the lower middle income countries. In our context in Nepal also, our neonatal mortality rate is static for the last 10 years. Because lots of hospitals has developed, lots of doctors are growing up, lots of pediatricians are going, lots of obstetricians are going on. Why it's not decreasing for the last year? Is it that we are lacking something? Why not? It has decreased from 21 to 18, or at least from 21 to 20 rate in Nepal. Maybe this newborn screening program, even there are some ethnic groups in Nepal, they allow marriage within their first cousins. Still they are present in some parts of Nepal. These things, these data, it says that there might be some prevalence of metabolic disorders in our country. Okay, in rural areas, the caste system is still adhered to, and it has been reported that 21.6% of parents will not allow marriage outside their caste. It is plausible that a proportion of newborn deaths may be attributable to involuntary metabolism. And newborn screening addresses an important gap in knowledge, not only in terms of establishing unexplained cause of neonatal death, but also in case of neurodevelopmental delay of unknown etiology. I think we need to explain to the parents, as we have lots of pediatricians here. I was talking to my colleagues just outside in the tea break. You don't know that we have the newborn screening program in our country. I think we are pediatricians are also lacking in knowledge that we are doing. I think that's why we need some awareness program among our health workers. And among the pediatricians, among the gynecologists, they should know. No? They will then counsel it, okay, this should be done. Because, paying 3,000 and 4,000, okay, the free newborn is not available till now, I just agree that. But there is the availability of, they can pay, no? But we didn't counsel them for the paying the patient. With 3,000, 4,000 paying for the newborn screening is not a big deal for at least for some publics. Not for all, but some publics. But we are not counseling for them. That's why I think we need the awareness program, and this is the good platform, that this is doing a good platform, and we should increase this type of conference, this type of awareness programs to all the pediatricians and gynecologists also. Okay, and there was a retrospective study in neighboring countries in India with investigating that known cases of IMS in pediatric intensive care units showed that 36% had a sequelae of irreversible intellectual disability. See, the prevalence is very high, even due to metabolic disorder, intellectual disability. These are the things we are facing in Nepal also. In our OPD also, we see lots of cases with intellectual disability, lots of developmental delays. We could not get to the final diagnosis, but we can feel the pain of the parents growing this type of children. If we can diagnose it early, it will be a great benefit for the. I think it's for not only for the parents, it will be the great benefit for the whole country. WHO estimated 1% of Nepali population has severe neurological disability, and 10 to 20% has milder mental illness. In fact, Nepal's health profile shows that 1.63% of prevalence of neurodevelopmental disabilities, of which 5.9% have intellectual disability. Speculation exists that many undiagnosed cases of intellectual disability in Nepal may represent survivors of missed metabolic disorders. Maybe we are missing the metabolic disorders, and these are causing the intellectual disability. The rate of disability was estimated to at 4.8%, of which 17% was reported to be due to the metabolic disorder. That's why early diagnosis is desirable because some of the metabolic disorders are treatable, just like in hypothyroidism. Just in the before slide, Dr. Bijay has shown how it's a treatable condition. Okay, about this study, this is a prospective cohort study which was conducted in our hospital between November 2021 to 2022 with late term and late preterm. We did not include the preterm babies in our hospital, and screening was done for the 6 disorders. Congenital hypothyroidism, G6PD deficiency, congenital cell content biotinase deficiency, and hemoglobinopathy. And initially, it was a challenge for us to train the staffs, to give the knowledge to the staffs how to do it. And staffs were trained on how to collect the blood samples, transport protocols, and were assessed on. Then it was sent to India. We don't have the system here. That's why we have to send to India for this. And this was done at the time of the COVID also. We faced lots of problem in transporting this issue from our country. Anyhow, we were successful in establishing this data. The objective of this study was to determine the feasibility of establishing newborn screening in Nepal using a limited number of disorders that can currently be confirmed and managed in Nepal, utilizing a process map for sample collection, transport, analysis, and result communication to healthcare providers and facilities. And other objective was to determine the accessibility of introducing newborn screening among maternal and child health providers and screen and enrollment. Is our patients, is our healthcare workers, are they ready for newborn screening or not? We have our second objective was that. I'll go in detail about the results also. Study inclusion criteria were infants born at greater than or equal to 34 weeks gestation. We didn't included the preterm babies. And some infants with high risk of or suspicion of metabolic disorder, they have been tested with the expanded panel. We have done an expanded panel for them. If any babies were admitted in NICU, if every baby is not improving with our normal antibiotics or normal procedures, what we are doing, if we suspect that the baby might have some metabolism, we have done a high-risk expanded panel. Okay, and similarly, it was also physicians were also allowed to do the expanded panel if they think that, okay, there are some other risk factors also, or they think that there might be metabolic disorders. What are the results? Results were that of 35 parents approached for the study, 25% consented. I think in Nepal, the consent is not a problem for the doing the metabolic screening, though it should be free of cost. If they have to pay, if the patient have to pay, they will not give consent. And if the investigations are free of cost, consent will not be a problem in our context. Parental surveys show that 92% consider the no cost option was the most important in choosing to participate in the study. And then samples were transmitted to Bangalore within the expected time, and results were communicated to parents within 9.5 plus minus 2 days. That was done. What were the abnormalities? It was 5 cases of hemoglobinopathy traits, hemoglobin E in 4 cases, and 1 case of hemoglobin D, 3 cases of congenital hypothyroidism, 2 cases of glucose G6PD deficiency, 1 case of congenital adrenal hyperplasia, 1 case of elevated extracellular carnitine, and 1 case of biotinate deficiency. At least we have found that at least 13 cases were positive in our 835 screened cases. And it corresponds to the other international data also. And what we found that the healthcare providers survey also showed that 67% of them have the moderate understanding of the newborn screening. All indicated, all healthcare persons said it is beneficial for it should be done, it should be beneficial. And the main thing is that everybody, it's natural that everybody thought that it should be done, it should be done. Okay, 90% thought that the screening should be done routinely. Okay. Despite this study sample is a very low, 800 samples, but with this study sample also, and other studies also, which show that we have the incidence of metabolic disorders in our country. It shows that. But why the diagnosis rate is low since we don't have the newborn screening tests are performed, and usually in case of high-risk cases, there are illnesses due to limitations arising from the economic factors. And so if any doctor suspect the cases, there might be some economical factors for which maybe the patient can't afford that treatment, or that case of investigation, maybe that's also in the factors in the case of remote areas also. Okay, now, yesterday also I have told that everybody getting convinced that newborn screening should be done, okay? But problem will be that if you talk with the government officials, there are some valid concerns from them. They will say that regarding the unavailability of comprehensive management, and in low middle income countries, it is uncommon to find projects vying for limited sources. Maybe they think, government officials may think that, is it we have to cut budget from other sources, no? To perform the program. They might think that, you know? And it might be that, as I said, there might be some anxiety associated with the diversion of funds from other areas of healthcare system, because the healthcare system, in Nepal, the budget allocated for the healthcare system is very low. I think it is around 6 to 7% only, and government has lots of priorities. No? Where should they send their budget? And there might be some debate might be that if government wants to allocate some budget to the newborn screening, then he has to cut some budget from other sources. There might be some debate. Okay, and okay, that's why we have to prove that. We have to prove that this is also a priority program. Just yesterday also we have discussed with our congenital anomalies, incidence of congenital anomalies are increasing day by day, year by year. We have to show to the government, we have to prove to the government that this is the factor which is causing the stagnant rate of neonatal mortality rate in our country. We should convince them. That's the main factor. Just like other low middle income countries, just like India and Philippines, they have successfully implemented universal newborn screening program in public hospitals. I think in Philippines, they screen for 36 diseases. No? Where the cost of services, are, including newborn screening, all are free of cost there also. That's why it is possible in our country also. Though many metabolic disorders are uncommon, but together they represent a group of disorders that contribute the highest significant morbidity and mortality. Many cases of IMs are still likely misdiagnosed, with unexplained deaths being attributed to more commonly occurring causes like infection. We have initially we think that it might be infection, but later it turns out to be metabolic disorders. I think Dr. Prajwal will talk about the challenges in our next presentation. We are facing, after establishing our newborn screening program in our hospital, we have our thinking for the diagnosis. We are thinking in a different way in our hospital. Maybe we are thinking that it might be a case of metabolic. Previously, we think that everything we treat as a sepsis only. Either it is sepsis, asphyxia or sepsis. But now we are thinking that this might be a metabolic disorder because the symptoms might mimic as a sepsis, neonatal sepsis. But baby is not getting improving. In that case, we think that this is the metabolic. At least we are now thinking. But I think this should be spread all over Nepal to all the pediatricians and gynecologists and all the health workers also. Okay, I just want to. Okay, now I want to conclude this case. With this presentation, I would to conclude my slide that we demonstrated that it is feasible to introduce newborn screening. It is feasible to start newborn screening in Nepal, but parents are overwhelmingly considered no cost. It should be free of cost, because with paying, patient will not. It's obvious that it is not possible to do. It's very difficult to convince parents to pay for the newborn screening. But at least if we can start it in the government hospitals, just I was discussing in the outside also, if we can start in the major hospitals, just like Prasuti, Fotoghar, Teaching Hospital, Partner Hospital, and BPKHS, if we can start these programs in the government, tertiary care government hospitals, then private hospitals are bound to do the newborn screening. Even patients will say that, or doctors will say that, why we are not doing in our hospitals? Even in Fotoghar, they are doing the newborn screening. Why we are not doing in our hospital? The parents will ask the doctors, and then the doctors will be bound to do it. See, I think, let's see, within 1 year, if we can screen all the babies in the Fotoghar Maternity Hospital, it will give a multiplication effect in the private hospital also. They will be bound to do. Otherwise, parents will ask, why you are not doing? In Fotoghar, they are doing, and you are not doing in our hospital. That's why, if we can establish the system in the major hospitals, for that, how we can link with each other, I think this is the good platform that we can, it may help us to make a good platform to have newborn screening programs all over in Nepal. And a government-sponsored program will be a key factor, that's sure, it's a key program. Okay, thank you all for this presentation. And if you have any questions, please. And at last, I want to show a slide. Okay. Okay, now I just kept doing some advertisement of my own society. I am being a joint treasurer of the Perinatal Society of Nepal. I would like to welcome you all in this FOUPS conference, this Federation of Asia Oceania Perinatal Society conference in Nepal. We are organizing in 14th November to 14th, 15th, and 16th November in Kathmandu in Radisson Hotel. And this is the first time all the Perinatal Society of Asia Oceania are coming together in Nepal, and it's a great pleasure and pride for us also. And we have almost, registration has almost crossed 200. And among them, 100 participants are from the foreigners. They are from Asia, Oceania areas. That's why I would like to welcome you all. Please do come. And it's a good platform, even for this newborn screening also, because it's a society of perinatal society. There will be obstetricians also, pediatricians also, and it might be, it surely is a good platform to discuss about the newborn screening. So I would like to welcome you all. With this, I think I'll close my presentation. And if any questions, please, you are welcome.
Yes, thank you. Thank you very much, Dr. Sailendra, for your groundbreaking research. And being a researcher, I can imagine that how difficult is it to execute a research in a developing nation like Nepal, starting from planning, securing your budget, getting IRB approval, and parental consenting, designing methodology, result dissemination and publication, and again promoting it for citation. So I think your research will form a foundation for upcoming researches in Nepal. So we have lots of pediatricians here today. I'm sure some of have a question for Dr. Sailendra. So the floor is open once again for question. Yes.
Thank you so much. Very good morning, everyone here. Actually, it is very great that we have the newborn screening laboratory well established in Fotoghar Maternity Women's Hospital. I just suggest that actually what are the barriers which we are facing now in your center for the newborn screening, which is only taking place in your hospital and not in even other hospitals like Patan Hospital, Teaching Hospital, TUTH, and other hospitals of Kathmandu. Actually, I just would like to suggest so that we can screen every newborn babies. We can have a meeting with all the directors of hospitals where birthing is going on in Kathmandu. And after meeting, we can transport all the samples to your centers and screen all the newborns. I think we have 9 members working committee now, and if it is functional, if it is active, then it's okay. Otherwise, we can form with these all the stakeholders which we are discussing since yesterday. So we can form a task force with including all the concerned like WHO, UNICEF, Ministry of Health, Pediatric Society, and other related national societies, and we can form a task force that will work. And in first phase, that I have already told, in first phase, we can start in Fotoghar Hospital for screening for newborn babies from all the hospitals in Kathmandu, first phase. And then I think it will be not that much difficult to strengthen all the provincial hospitals. So these children, this Fotoghar Maternity Women's Hospital will be the center for the newborn screening, and just for one test, just for congenital hypothyroidism, we can establish laboratory in all the provincial hospitals. And then in provincial hospital, just one test. And sample will be sufficient because birthing is free in all the primary health care centers in Nepal government hospitals. So just we need to transport samples from the different hospitals to the provincial hospitals, so that we can do the second phase. And last one suggestion that this discussion should not be just for discussion, because we from everywhere, we from the different countries here, and if it will be only for discussion, then nothing will happen. So now I today 9-member committee you have that will work today and form either active committee or the same committee which will be functional, including all the stakeholders. Thank you so much.
Thank you. Yeah, that's right. how I think this platform, this committee will can make a can make a breeze between all the other hospitals, government and private hospitals. Especially, let's talk about the government hospital first. I have just told you that we can just have a tertiary care government hospital, just like in Kathmandu, we can have a bridging between Fotoghar teaching hospital, Patna hospital, BPKHS, and in other hospitals in the states also. We can then go to the medical colleges. No? And this is this platform should perform a bridge bridge-like activity. They can make this is also a good platform. We have bridging with lots of people here. This type of conference, this type of, will make a bridge between all, and it's possible that. It's possible to, it's not a very difficult task. We have to give message to the director or pediatricians that it's not a difficult task. It's a possible task, and we can do it. This will encourage everybody, and I think that's a good idea that we can collect samples from other hospitals, and in every state we can make one centers where we can have a test. And if we have the more incidents, then they will establish their own lab systems.
Dr. Sailendra, one question,
Yeah.
Finding 13 abnormal cases out of 825 babies. I just wanted to know what was the next step? Were the baby followed up and provided treatment?
Yeah.
Were they confirmed? And then what happened to those 13 cases?
Yeah. This was a challenge. This was the challenge for us. Anyhow, we conducted, I think Dr. Prajwal will discuss on the challenges after diagnosing the cases. We will discuss in the next slide. But in our study, what happened? Among somewhere, almost everybody, because we have recruited one staff for collecting this blood samples, transporting it to the lab, and then communicating with the parents. It was a little bit easy for her. She has communicated to all the patients. One case of CAS was we could not treat them. We could not convince them. Actually, I say that it's our fault. When CAS was diagnosed, other cases were followed up. We will follow up. They came to our follow-up also, but later they lost to follow-up. One CAS case we tried very lot. We have tried lots of time. We called them, and they didn't come from the conformity diagnosis. And later, the baby expired. And somehow I feel that it's our fault. We cannot convince them. This might be a challenge. Dr. Prajwal will ask. This is the challenge, because still we are in that area of our health that our population is such an area that till they don't have any symptoms, they will not go to the doctor. They will not believe you. Even in case of it is in case of pediatric side population, even in case of that is in case of the adult population also. I think this is the same problem in our neighboring countries, of India, Pakistan, Bangladesh. I think this is the same problem. It's not like New Zealand and other countries. You cannot convince the parents till you will find the symptoms. Now, sometimes I say that my father was hypertensive, and I have to convince a lot to start medicine to my father. And sometimes I think that in my family, I may be a doctor, my father being a professor, I have to convince a lots of time to start medicine, hypertensive medicine. What will happen to the other population? How can you convince that you have to do newborn screening, you have to start medicine, till the symptoms will not start? And when symptoms starts, it's very late. This is the thing, no? That's why I'm saying that first we have to convince our health workers. Our health workers are not convinced. Then we'll convince to the parents, then we'll convince the population. It's a very long chain effect. I just gave the simple example in my family. Even there are lots of people, they don't start medicine. I think the internal medicine doctor is here, Dr. Robin. You have to convince a lot to start anti-hypertensive medicine or anti-diabetic medicine, isn't it or not? But everybody knows that you have to start medicine in hypertension and diabetes, but still we are lacking. Then our people still don't know about the newborn screening, newborn diseases. So that's the challenge. That will be the challenge, and it will be forever it will be the challenge. We have to convince that your symptoms will appear later on. You have to start medicine now. You have to change your diet. You have to do investigations. And for that, you have to allocate a different person. One physician cannot do all the things here, because physician will be busy on other things. Sometimes when you call, I think Dr. Prajwal will, we have a bitter experience. In case of one patient, we have called them, okay, your cases has given positive, the patient has already been expired. And I was frightened that you will come back and get fight with me. Why you didn't tell me earlier? No, you are doing the test, and why you didn't tell me earlier? I could have done the treatment. But these are the challenges you will face. Surely you will face. Because everything, we cannot do all the things, possible ways are not available. We have to convince them, and we have to send to the appropriate, for the appropriate treatment also. These will come in challenges.
Yes. Thank you, Dr. Sailendra. I think knowing a challenge is itself a challenge, and you have currently pointed it out. So we'll move to our next session.
Okay, thank you all.
Thank
we can have discussions in the free time, I think.
Thank you so much, sir, for talking about the locally manageable disorders, need of awareness among the public as well as medical professionals regarding the newborn screening, and justifying the need of screening program at governmental level. And I think this conference today will definitely bridge the gap between the newborn screening in to-do list. So. Moving further, to share his experience in establishing newborn screening in standalone laboratory, we have Dr. Jeevan Adhikari, a consultant pathologist at National Path Laboratory, with a blend of traditional diagnostic expertise with molecular approaches. He is committed in advancing the incorporation of molecular genetics into the routine pathology practice, thereby improving the diagnostic precision, personalized care, and preventive health outcomes. So let's welcome him with a big round of applause.
Hello and namaste. My name is Dr. Jeevan Adhikari. And before starting my presentation, I would like to thank the team BTC, especially Dr. Santosh, Dr. Vivek, for organizing this kind of program, the first of its kind. Because you know, in Nepal, by going through so much of presentations from yesterday, even I didn't know that so much of thing was happening all around in small pockets. Like I didn't know Dr. Vijaya before this presentation. I didn't know her contribution in this field. So, and even other presenters. And so thank you, especially Dr. Santosh and Vivek, for organizing this and like uniting us all together so that we can work as a team. And me representing the private healthcare sector. So how I can contribute in this field. So once again, I would like to introduce myself. My name is Dr. Jeevan Adhikari, and I'm a consultant pathologist working as a head of the labs at National Path Lab. And so before starting my presentation on the NBS, I would like to give a brief introduction on about my lab. So it's a 13 years old, largest chain laboratory in Nepal, with nationwide coverage. We have around 13 standalone lab and 3 hospital laboratory managements, including one at Manipal Medical College, where we manage the lab over there. Among the 13, we have 2 NABL ISO 15189 2012 accredited lab, and we have NPHL approved A category labs. And one of the labs in which I work is located in Lagankhel. So it's a state-of-art genetic lab equipped with advanced genetic testing platforms for cytogenetics. Especially, we do the test like karyotyping and fish over there. And we have molecular genetics, which is NGS-based test, in which we are doing NIPT, we are doing cancer gene panel testings, and in nearest future, we will be doing PGTA testing as well. And whole exome sequencing is in our pipeline. So within this year, we will be doing whole exome sequencing as well. And we have a newborn screening platform as well. And we have molecular biology platform that is PCR-based tests. And we have the widest test menu, that is 800 plus in-house testing with specialized and exclusive tests. And we have an experienced team of experts, including, we are 14 pathologists over there working. So, as a part of our strategic expansion, we are aiming to enhance our testing capabilities by establishing a cytogenetic and molecular lab. And we are focused on wide range of tests like karyotyping, FISH, NIPT, comprehensive cancer gene panel testing, PGTA, whole exome sequencing. And we also wanted to establish a platform for newborn screening to complete the perinatal testing ecosystem. Because since we are already in a prenatal segment, so why we won't cover, so there are no any questions asked. So we started newborn screening lab for that to complete the ecosystem. So then we started exploring. And since we already had a reference laboratory at Maharajganj, so we are getting very limited demand of newborn screening from our service givers and clients. And we are very few tests that were being produced, and we used to outsource them to international labs. And most tests were primarily mass TMS based, and they were for sick people, sick children, for NICU and NICU based especially. And they were screening for inborn error of metabolism. However, in the global context, newborn screening was gradually gaining momentum. It was popular in US, Europe, Asia Pacific, especially the Philippines region, and a few states of India like Delhi, Kerala, and Goa. And during the quest of whether establishing national newborn screening lab at National Path Lab or not, then I went through this article. So this article was published in Indian Journal of Pediatrics in 2014. It stated newborn screening, the need of an hour. And while I was going through the article, I found that it was mentioned WHO has often recommended that genetic services should be introduced in countries with an IMR less than 50. So newborn screening, and I went through this, the references, whether it's provided or not, I didn't find the reference. But since it was published in such a prestigious journal, I agreed to what the line was saying. And this gave me a boost to introduce NBS lab and to set up NBS lab. Because we are currently running at 23 per 1,000 births with a goal of reducing to 11 per 1,000 by 2035. This reinforced our confidence that we can contribute to this effort, because so many things was done for infectious conditions like vaccinations and all, and so many things were being done for prematurity and all. So what next can be done? So we went along with this, and so how could that be done? So it was a question. So before establishing, we are very open that without a government collaboration, it won't be a success. And only by focusing the urban health initiative also, it won't be a success. So there has to be both way around. So we are committed to making a meaningful impact after that. So another challenge was to identify the right platform. So to ensure the success of our NBS program, we researched and engaged with several established lab in India with NBS capabilities. And through extensive discussions and research, we partnered with Revity. Revity is a world-renowned platform in this field. And we also found our local partners who were associated with Revity, and that has been an instrumental in establishing NBS lab in Nepal a reality. And we set up these instruments. This is the Vector 2D setup. And from the DBS puncher to analyzer, these are the instruments which are required for NBS using DBS cards. So designing the test panel was another challenge for us. And since there are very limited number of published articles and case studies on NBS in Nepal, we turned to research conducted in neighboring countries. And based on those studies and panels implemented by established lab, we designed a testing panel tailored to Nepal's need. And our approach reflects a balance between available data and international best practice. And if sufficient local research had been conducted earlier, we could have curated the panel more precisely. And nevertheless, we moved forward with the best available evidence, ensuring the panel's relevance to Nepal-specific healthcare landscape. And currently, our panel consists of CH, CAH, cystic fibrosis, PKU, galactosemia, biotinidase deficiency, and G6PD deficiency. And we are in a constant touch to integrate hemoglobinopathy as well in this panel. Because as we all know, in Midwestern and Far Western region, especially in the Tharu population, how prevalent this hemoglobinopathy is. So to cater those population, we are trying to integrate that as well. And we started the promotional campaigns. I'm talking about around 6 to 7 months back, not long. And once the lab was set up, we launched promotional campaigns. We mainly targeted the corporate hospitals, although side by side, the government lobbying part was always there. And we asked the corporate hospitals, the renowned corporate hospitals of Kathmandu, to integrate NBS in their perinatal packages. However, we encountered a big resistance from many healthcare providers, the who is who of pediatricians of Nepal, and they were concerned about the additional financial burdens on the parents. And we asked them only for 7 tests, it was like 5,500 rupees. And if the case burden was increasing, then we can reduce the price. But still they found that even in the corporate hospital, that we are increasing the financial burdens to the parents. Despite our persistent effort, including multiple presentations and pitches, there remained hesitation to embrace the new initiative. During the same time, Fotoghar hospital's newborn setup was also being done. We were setting up parallelly, and while some doctors who were aware of the fact that Fotoghar hospital newborn screening setup is being done at Fotoghar hospital, they expressed interest in learning about the program, and the number of enthusiastic adopters were very insufficient to ensure the lab's sustainability. And we continue to face this challenge in engaging the key stakeholders. And what is the current situation? The current situation is that it's not that we are not receiving the samples, we are, but it's not enough for long-term sustainability. And after thorough analysis and a lot of brain twisting kind of discussions, we are now convinced that the success of this initiative will require government intervention at policy level. First of all, in my opinion, the government must prioritize to a wide or large-scale research, including more than 10,000 cases, to assess the prevalence of this so-called rare disease. But I don't want to call them rare disease because they are not diagnosed. And that's why I've mentioned so-called. And impact of this disease on the family and society. which will help guide the focus of the newborn screening program. And awareness to the, first of all, to the health professionals only, and later to the general public comes next, because we will be having good data backed regarding the incidence of all kind of diseases. And then a phased approach could introduce prioritizing these conditions most likely to impact the infant survival. So initially doing research, we can go with 7 or 8 parameters. Then while implementing it in the national health policy, national health program, then we can choose the top 2 or top 3 diseases that come. And this should be incorporated into the national health program and accelerating our progress towards achieving the 2035 IMR target. So my conclusion of this discussion is, of my presentation is, although we are currently struggling with insufficient sample collection, we remain optimistic about the future, because once the government will push, then it will automatically drag the private hospitals and private stakeholders as well into this. And our lab system is in place. It is ready for diagnostic testing, and it's open for the research purpose. So if anyone is interested for doing research at our lab, then we are quite open to this. And true to our name, actually our full name of our lab is National Path Lab and Research Center. So it can be a hub for research as well. And once policy level changes are implemented, we are confident that only government-based labs like Fotoghar will not be able to handle the overflow of sample alone, and it might heighten the need for expanded facilities and resources. And having said that, because we have platforms as well, so for once the screening test comes positive, for confirmatory testing, we can use our platform for confirmatory testing as well. So that's a good part, because we have like PCR-based platform. So if cystic fibrosis IRT comes positive, cystic fibrosis test comes positive, then we are always there for doing the CFTR gene mutation or detection by PCR. So we have a diagnostic platform as well. And we are always open to like collaborate with government. So we have a good history of like how we collaborated with government for COVID-19 testing. So it was way back when COVID was a huge thing, and we provided our RT-PCR platform to the state government to run COVID-19 testing, because private labs, although we had platform, we are not allowed to like perform the testing. So we like for some time till we get the permission for doing COVID-19 testing, we provided it to the state government. And later on, like we were the first lab outside the Kathmandu Valley to provide COVID-19 testing facilities in a private setup. So we have a very good, we are very open to government collaborations as well in that aspect. So with this, I would like to thank you all. And once again, I would like to thank Dr. Vivek and Dr. Santosh for doing this wonderful event. And I would like to thank the international speakers as well for coming here at such a crucial stage of our country. So, and at conclusion, I would like to show this picture. Picture. Okay. That picture speaks like more than 1,000 words. And I guess this has been displayed since yesterday. So this is a very good, like, very good picture to pitch to anyone, because both of them were like born CH, congenital hypothyroidism. One was screened, the girl was screened with NBS, and she turned out to be, she was diagnosed and she started medication, and she is 7 years old now, looking perfectly fine. And the rest, and the next guy, he's a 15 or 14 years old kid, and he was not diagnosed at birth. No newborn screening was done. That's why his condition is like that. So it's a newborn screening is like a boon for the lady over here, for the 7 years old kid over here. And so thank you so much, and thank you for inviting me here and asking me to share my experiences. Thank you so much.
Yes. Thank you, Dr. Jeevan, for your wonderful presentation, and thank you for thanking us back in again. Thank you. So thank you once again for starting and initiating this state-of-art technology in Nepal. So you are a true inspiration for our generation, for the entrepreneurs, young entrepreneurs, for upcoming generation. So we'd love to hear question. The floor is open for question, if anyone wants to. Yes.
Dr. Jeevan, I would like to know how many samples have been received so far, and how many tests, how many cases were detected and confirmed
Till now,
after the program has started?
we have processed in the last 2-3 months. We have processed around 60 samples, and none of them are positive till now.
Thank you, Dr. Jeevan. So
Thank you once again. Thank you.
Thank you, sir, for connecting the theme starting from the clinician's perspective to laboratory sustainability and notifying us about the WHO recommendations about genetic services, and also about the services provided by the National Path Lab that includes 7 panel for newborn screening and further plan of integration of hemoglobinopathies, and I hope that will quickly be successful. So conference like this, of this scale, is not possible without our sponsors, and because of the generous sponsors, we are able to conduct conference like this that help in bridging the gap of various medical knowledge that we still lack. So I would like to welcome representative from Revity for their words. Thank you.
So good afternoon, everyone. I'm Sandeep here from Revity. I am giving a warm welcome to all of you for this conference on newborn screening. So Revity is a company which is providing commitment to maternal fetal health and newborn health across the world. Before we jump into the solutions that we have, so Revity was earlier referred to as PerkinElmer, and we had analytical life sciences and diagnostics companies. And then in the meantime, we acquired a lot of diagnostic life science companies like Euroimmun, BioLegend, and all. And that's when we decided that we will sell off our analytical and food business, and also we sold away the brand name of PerkinElmer, because we wanted to be known as Revity, which is focused on diagnostics and life sciences. So Revity is a solution provider, and we are there for serving across more than 110 countries. So we are serving governments, we are serving clinical labs, biopharmas, CROs, and academia. So we are the #1 company in terms of newborn screening, #1 company in terms of prenatal screening, autoimmunity, and tuberculosis, and latent TB testing as well. So Revity is a global market leader in the newborn screening, and we provide end-to-end solutions, starting from sample collection to report generation. So we have been in the market for more than 35 to 40 years now, and we have been screening around 18 million babies from past 30 years with our solutions. And we are helping more than 50 plus labs across the world for the newborn screening solutions. And with that, with our screening solutions, we are able to save around 85 babies on a daily basis with our screening solutions. Sorry for a busy slide, but here it shows you how the Revity was formed in India and how we have been supporting the newborn screening labs in India and South Asia. So we also help customers in Sri Lanka, Bangladesh, Maldives, Nepal, and Bhutan as well. So if you look at, if you look at the whole screening process, I think 2006 the screening started in Sri Lanka and Bangladesh as a pilot-based project where they started screening for CH. So they used our equipments called VT2D for screening. And then also in India, ICMA conducted a study for CH and CH across all over India for a lot of newborn babies, and they found out the prevalence of these disorders in India as well. Again, similarly, we have a lot of programs like Chandigarh program, we have SGPGI Lucknow program. These are being ongoing from a very, very long time, and they are screening for these various disorders of newborn screening from a long time. And also we started, so we expanded, with our health solutions, we expanded the screening in Sri Lanka. So now Sri Lanka is doing a nationwide screening for CH. So they are covering more than 95% of the newborn babies across. And they have VT2D and Adelphia instrument with them for the screening of CH. Also, we had a lot of publications from SGPGI that were coming in the meantime. Also, in India, at the same time, we started with the first state-level project at MAMC Hospital in New Delhi under Dr. Seema Kapoor. Started with the screening of basic disorders of newborn screening, and then she expanded to the expanded panel of newborn screening as well. So now they have been working with us for many years, doing newborn screening for the state of Delhi. And they have a GSP and VT2D instrument for newborn screening, and also they have a mass spec also which is referred to as QSight for newborn screening. And they're looking to have increase the foothold across for the screening of SMA and also the hemoglobinopathies as well. Similarly, we started with another statewide project in southern part of India called Bangalore. So there also we have been giving solutions for newborn screening at One Wellness Hospital. So they have been screening 5 disorders from almost around 10 years now. And they have screened a lot of babies, and also good thing is they are screening and also they are getting confirmation tests done, and also treatment is provided to all the newborn babies who are identified. Similarly, we have been doing, so again, we got publications from ICMR and other things. And then we also started, the newborn screening in Malé, in Maldives. So at Indira Gandhi Institute of Hospital, so they started also newborn screening, for 5 disorders using VT2D instrument. And then also we continued our growth. So we started with the 3rd level state project in Maharashtra. So Maharashtra has been doing the screening program since 2017, and they have been screening for CH and CAH for all the newborn babies across state of Maharashtra. Then they have a GSP instrument and punches for the screening process. Similarly, we got a lot of publications. So again, like SGPGI or PGIMR, GMCH, they have been doing a lot of publications reporting the prevalence of CH, CH, D6PD across India in different regions as well. And also we expanded the newborn screening in Bangladesh. So it was under the project at NINMAS. So they started the newborn screening for CH for across Bangladesh also. And they got our GSP and Adelphia instruments for the screening of CH across Bangladesh. And also, the first private laboratory in India called Mahi also acquired, and they did a lot of big project on newborn screening solutions. And then as we move forward, again, of rare disease policy in 2021. And they grouped disorders into group 1, group 2, and group 3. And there have been a lot of center of excellences now, which are created. And there are a lot of Umid Kendras or Nidan Kendras have been set up in India now for newborn screening. And most of them, they have procured an instrument already from ours. And they are in line with publication. The first publication was the cost-benefit ratio analysis from the Manipal Academy of Education. It is at Manipal. So they published that CH, and G6PD have a long-term effect if they are screened and treated properly. So cosmetic nutrition is much better if it is not screened and not treated across. So we need a lot of those studies in reducing the NMR rate that we discussed this morning. So again, similarly, we have a lot of government projects which are going on now for the newborn disorders. This slide actually shows that we have a wide range of installations across India and South Asia. So we have more than 76 laboratories installed in India and South Asia. So as I mentioned, we are running newborn screening program at Sri Lanka. We had done it earlier at Bangladesh. We are doing it Maldives, and also we are doing it a lot of state government projects in India as well. So Revity doesn't only provide the instruments and solutions. So we go a long way in improving the newborn screening, providing technical expertise, and hand-holding for the labs to start and continue the newborn screening for a very, very long time. The slide on the right-hand side shows you the installations that we have at government institutes in India and across South Asia. So we have installations at 4 different All-India Institute of Medical Sciences, that is New Delhi, Bhatinda, Bhopal, and Mangalgiri. And then we have at MAMC, PGIMER, GMCH, Vani Vilas, Bangalore, Indira Gandhi, SGPGI, NIMANS, so take on, right? So all these laboratories are doing newborn screening solutions, and we have a lot of private customers also. If you talk about Dr. Lal Path Lab, Metropolis, or LifeCell, or MedGenome, they have also the similar instruments for newborn screening. So Revity is a complete solution provider, starting from sample collection to report generation. So we provide complete solution in terms of newborn screening. So we cover the basic panel of newborn screening, that is 7 disorders, plus DMD. Then we have the expanded panel of newborn screening with our mass spec solutions, where you can do amino acids, fatty acids, organic acids, and LSDs as well on the mass spec instrument. Also, we have specialized testing available for hemoglobinopathies using our MyGel instrument that is in gold standard for hemoglobinopathies. And also, we have EUNIS, which can be used for screening of SMA and SCID also in newborns. And as I mentioned, we already have a lot of data available with us, especially from India, Sri Lanka, and Bangladesh, which tells you the prevalence and also the cutoff ranges that is required for a lab to start, in the initial time. And also, we are the complete solution providers for the prenatal screening. So we have a range of instruments for mid-sized and big-sized labs covering the whole screening of Down syndrome, Edwards syndrome, Patau syndrome, and preeclampsia in all the 3 trimesters. And our solutions for prenatal screening are Fetal Medicine Foundation approved and CIVD approved, and our solutions for newborn screening are CIVD and USFDA approved. And also, we are the pioneers in diet bed spot screening. So we have diet bed spot screening solutions, not only for newborn screening, but we have also for prenatal screening. So we are the pioneers in diet bed spot technology. So as I mentioned, we are a complete solution provider, providing a complete solution starting from sample collection to report generation. So we have the instruments, the reagents, and the softwares required for reporting. And as I mentioned, we go a long way. We just don't provide the instruments and reagents, but we make sure that whatever technical expertise is required from the laboratory, whatever handholding is required by the labs to start the newborn screening and also to take it a long way. So like, for example, Sri Lanka is an example of that. We have example of Maldives. We have several state projects in India which we are doing, are all examples of how we have been continued with those labs in continuing the newborn screening for their particular province or region. So if you come to newborn screening solutions, as I mentioned, we have a semi-automated instrument called Victor2D, which can do newborn screening and prenatal screening. We have GSP instrument, which is used as an automated platform for newborn screening. So a lot of state government labs in India has also installed GSP instrument. And we also solution providers in terms of the expanded panel of newborn screening. So talk about amino acids or fatty acids, we have an instrument called QSight, which works on the LC-MS principle. So we provide the instruments and we provide the reagents also for the expanded panel of newborn screening. And we have EUNIS-Q, which is again state-of-art instrument for the screening of SMA and SCID and cytomegalovirus as well for screening, which runs on a PCR-based technology. And then we have MyGel, which can be used for screening of hemoglobinopathies, especially thalassemias and sickle cell disease can be screened with these. So as mentioned, we have the sample collection carts, which are CLSI approved and which are FDA approved for newborn screening and prenatal screening. We have sample preparation kits in terms of punchers. So we have DBS puncher and we have Panthera puncher, which is required to do the newborn screening program. And as mentioned, we have instrument called BTC, which can do these many tests of 7 disorders. And then we have GSP, which is an automated platform for newborn screening, which can do screening for CH, cystic fibrosis, G6PD, PKU, and Duchenne muscular dystrophy as well. And then we have UNIS, which can be used for screening of spinal muscular atrophy, SCID, and XLA. And then we have MyGel, which can be used for sickle cell and hemoglobinopathies. And then we have mass spec called QSight, which can be used for the expanded panel of newborn screening as well. And more importantly, we provide an end-to-end solution. So we're also providing softwares which are required for patient reporting for all these newborn assays. So this is an instrument that has been installed also in the first laboratory in Nepal at National Path Lab, as Dr. Jeevan mentioned in his previous talk. So we have the instrument which can be used for newborn screening of 7 disorders and also the prenatal screening disorders as well. So with that, I would like to end my session. Thank you so much.
Thank you.
Revity has been serving us for more than a decade with great progress worldwide. So now I'd like to welcome our another sponsor from Lab System to keep their words. I welcome a representative from the Lab System. Thank you.
Good afternoon, everyone. First of all, I would like to introduce myself. My name is Kumar Shubham, and I am representing Lab Systems Diagnostics, a company based in Finland. So since yesterday, I was hearing so many things about the challenges, implementation, and all the details for newborn screening in Nepal and other such countries which are not having a screening program yet. So before I get into the details of Lab Systems Diagnostics and its offering, I would like to go a little bit on the forward side. And first, I would like to discuss about the challenges, implementation, and I would like to propose few things for all of your opinion. So I'm going a little forward. I'm not going to start the presentation on Lab Systems as of now. Just give me some time. So this slide I have prepared in case if I get a time to discuss. This slide was already shown by Dr. Aisha earlier. And this slide was taken from the data ISNS presented in APHL 2023. So this is the data which I think all those who are having a NBS or doing NBS might have this kind of data earlier and have seen it. So here are this first slide about the global scenario. And yet we are saying after doing so much of efforts from international organization, regional level, everyone, we are still lagging behind. We are only to less than 30% of newborn screening getting screened worldwide. First slide. Second, I would like to show, about the technology advancements. From 1960, we are continuously developing the technologies to reach out each and every baby is screened in all possible ways. But we are still not able to touch less than almost 50% of the global newborns. What we are lagging here? I think we are lagging here some of the major things which I would like to present here as an opinion, and I would like to, again, get your feedbacks on it. Just imagine a situation where a gynecologist suggests tests to a pregnant woman, first trimester, second trimester, third trimester, and they go for it. They do go for the testing purpose, whatever, because they want their baby to be well and fine. I suggest to have a similar kind of approach in case of neonatologists and pediatricians. It's like a complete package, plus gynecologist and neonatologist. So once gynecologist suggests a test that needs to be done on the pregnant woman, same way the neonatologist has to prescribe that they have to go for the newborn screening for the good of their baby. If the doctor is going to suggest these kind of things, I'm sure almost I will say almost 90% of the patients who are going to doctor, and if doctor prescribes something like that, you have to go for this kind of medicine, they go and they take it. So why not the clinicians, the neonatologist, the pediatricians just offer in the prescription that, okay, this is your newborn baby, and for the wellness of them, please have newborn screening done. I think this is the most, I will not say easy, but yes, it is more ethical. At the same time, you are getting approval from the parents. At the same time, doctor is also suggesting, and at the same time, it will be taken care of. But in order to do that, in order to achieve this newborn screening at, I will say, on higher scale, I think we have to first educate all the neonatologists, just like gynecologists, what they are going to confirm, what they're going to prescribe. The same way, the neonatologist and the pediatricians must suggest and have the idea and knowledge of newborn screening and the disorders. So these are with few slides, I would, with my opinion, and I think I will get some feedbacks from you as well. I'm getting back to my conventional presentation on lab systems, what we are and what we are offering. So before I start my presentation, I would like to thank Dr. Santosh Pradhan and Dr. Vivek for conducting such a nice and informative session on newborn screening since yesterday. So what we are. So Lab System is a Finland-based company, and we are majorly focused on doing newborn screening worldwide. Besides newborn screening, we are also having different kind of product portfolios, like we are providing gastroenterology, point-of-care tests for celiac disease and Helicobacter pylori. In infectious disease, we are having an ELISA kits for Mycoplasma pneumonia, Chlamydia pneumonia, and Chlamydia trachomatis. Apart from that, we have few point-of-care tests in infectious disease, and also reverse transcriptase, real-time PCR tests for multiplex, respiratory multiplex diseases. In last couple of years, we have also started developing kits for HPLC and LCMSMS, not in newborn screening, but yes, for clinical diagnostic purposes. For example, vitamin A and E, vitamin C, as of now it is in research use only. Immunosuppressants, again it is in research use only, and we are having a good pipeline and in the R&D stage to coming up more HPLC and MS-based reagents. Focusing on Lab Systems' comprehensive newborn screening solutions. So we have categorized our newborn screening reagents into 3 different parts. The first is the core panel, that is the routine tests, what we discuss about TSH, 17-OHP, IRT, all those we have kept as a core panel or routine tests. Another one we have is an expanded panel on tandem mass spectrometry. We have NeoMass AAC+. NeoMass is nothing but neonatal and mass spectrometry, screening amino acids and acyl carnitines. And we again have another kit with some little more analytes, NeoMass AAC 3.0. Then we have advanced panel. We have reagents for neonate SCID-SMA on the real-time PCR platform. And we have one slightly different kind of reagents. That is, we can say the confirmatory test, or I can say it's a second-tier testing for testing the screened positive CAH. So this is an LC-MS-MS based kit, and it is called NeoMass CAH. In this, we are having 6 different analytes, steroid I can say, which detects and gives a little bit of confirmation about the false positive 17 OHP screened tests. On the instrumentation part, we have on fluorescence-based immunoassay, these are the instruments which we have. So the first one is on the left side is NS2400. It is our fully automated instrument. All the robotics and everything is inside it. And we also have a 4-plate DBS puncher. As you all know that the newborn screening starts with heel pricking and collecting the samples on the filter paper. So this is what we have. And on the other side, for small laboratories, for small to mid volume samples, we have the semi-automated modules like reader, washer, disk remover, and incubator shaker. So if you have a good sample volume, monthly or yearly, we recommend to go with our fully automated. And again, DBS puncher is always a standalone instrument. And if you have a small sample volume, you can go with the semi-automated platforms. So here are some key highlights about our products. So whatever kit we are using, the same kit can be used for fully automated as well as on the semi-automated platform. So you don't have to switch between these two platforms. Another thing, we are quality assurance compliant. We are participating in multiple external quality assurance programs globally. We have exceptional stability of our reagents and open kit stability and live shells. As I have mentioned, same kit are compatible to both automated and semi-automated platforms. And we have all the kit components included in the kits itself. So besides that, we also work towards innovation. And in the last couple of years, we have developed or we have upgraded our kit. For example, we have first launched our NeoMass AAC Plus kit. And this was we have some unique features earlier. And we were used to screen the complete urea cycle disorders for distal as well as proximal. Then we have also done some enabled the extraction of succinyl acetone without any kind of derivatization for screening tyrosinemia 1, which is still a challenge for in some part of the world where they are using home brew method or some other kits. For SMA kits, we are having both the genes like SMN1 and SMN2. Again, it is a real-time PCR-based reagents. And again, the NeoMass CAH, it is like a second-tier testing, which I have already mentioned, for the congenital adrenal hyperplasia using the same DBS sample as the 17 OHP screening. So in that case, you don't have to go for a baby recall or you have to collect the sample again. The same DBS card can be used for testing the CAH for second-tier testing. So recent developments, as I have mentioned, we have upgraded our NeoMass AAC Plus kit, and we have included a few more analytes which can enable the screening of adrenoleukodystrophy as well as the ADA skid, apart from amino acids and acyl carnitines. Again, for neonatal skid SMA real-time PCR, we have different variants and pack sizes to compatible with low, mid, and high laboratories sample volume. For future innovation, we are working on next-gen sequencing panels for newborn screening for different genetic disorders. We are also working on developing fluorescence-based immunoassay lysosomal storage disorders as well as DMD. And in real-time PCR, we are coming up with cytomegalovirus as well as multiplexing the SCID, SMA, and sickle cell disease. So these are some of the things which we are working on right now, or maybe by year or something we will have this launched in the market. Overall, this is our customer basis installation and at global platform. So we are screening around 4 million babies worldwide every year by using through our channel partners and trusted our distributors here globally. So with this, I am closing my presentation. Thank you.
Yes, thank you, Subhamji. Thank you, our sponsors, Revity and Lab System. Without you, our program wouldn't have been successful. And I request all our participants to engage with our sponsors, representatives from Revity, Sandeepji, Hardik is there, Devendraji is there, and from our lab system, Subham is there, Navinji is there. So I request all of you to visit them directly at their stall or engage with them during informal sessions, during and after lunch. So I think it's time for a well-deserved lunch now, and we'll see again after lunch. Thank you. Okay, so lunch is being served downstairs at Mint. So we have to take the stairs to down. Thank you.
With our set-centric, it has to be collaboration.
I was born with this